Hello and welcome to another podcast. Today we're going to talk about glucose emergencies. Now, if you're hoping for a bunch of awesome recipes to fit your cravings in the state of depression or loneliness, then you've come to the wrong spot. Today we're going to talk about the emergent states of patients when their glucose levels are either too high or too low. Now, a bit of a caveat for those listening. In the absence of diabetes and diabetic medications, and in some cases alcohol, the probability of getting into emergent state of high glucose or low glucose is excessively rare, but not impossible. And the fact that people can get in this state in the absence of known risk factors means that it still needs to be understood. And it really needs to be understood based on what you can do depending on the environment you're in. So today we're going to go through the highs and the lows of glucose emergencies, and we're going to really look at what is happening, the probability of it happening to people without certain characteristics, and then really focus on what we can do and what you should do in the case you identify one of these emergencies. So as a means of introductions, we'll just talk about the umbrella term that is glucose emergencies. Now, glucose emergencies occur in the both extreme low and the extreme high ranges. And depending on how high or low the ranges are, will depend on what sort of conditions you're dealing with. So at the absolute extreme ends, you're looking at shock and coma. But before you get there, you go through states of hyper and hyperglycemia. Once you get to a certain level of hyperglycemia, you move into the realms of diabetic ketoacidosis, and a term that has evolved over the years. So the term now is called hypoglycemic hyperosmolar state, or HOS. But back, wasn't that long ago, it was called hypoglycemic hyperosmolar non-ketotic state, or coma. Now, the reason they've changed it to HHS is because it gave an illusion that HHS couldn't involve any ketone bodies at all. Now, whilst the characteristic feature of DKA involves much greater levels of ketosis, it doesn't mean that HHS has zero levels. So they've changed it to HHS, so hypoglycemic hyperosmolar state, meaning whatever is causing that hyperosmotic state in the presence of high sugar is still the same umbrella condition and gets treated the same way. So if you see those other terms read out, just know that now they are talking about HHS. There's not a different classification out there. When we look at index, and when you do a lot of reading of studies, because different countries like to do different things, you need to be aware of the numbers that we're talking about. So despite the fact that the picture in front of you has 800, 400, that's talking about milligrams per deciliters. Now in Australia, we don't quantify glucose levels by milligrams in deciliters. We use millimoles per litre. And as you can see on the table on the right, you'll see the correlation of the numbers that we're talking about based on the comparative rate. Okay, so just be aware when you're reading out there, it's not a special glucose test, it's just depending what sort of measurement they're using. So today we're going to be focusing on millimoles per litre, just to be aware. Okay, as it says, let's start with the high. And we'll talk about diabetic ketoacidosis and hyperglycemic hyperosmolar state, which will be HHS from now on. So these two represent extreme ends of the spectrum of decompensated diabetes usually. So DKA and HHS remain very important causes of morbidity and mortality among the diabetic community. And despite the fact that diagnostic criteria and treatment protocols are getting better and being researched all the time, there's still high cases in the diabetic community. Now, to give you an understanding of how prevalent it is in that community, 2/3 of adults that present to the emergency department or are admitted with DKA have past history of type 1 diabetes. Okay, so they have type 1 diabetes, 2/3 of them. And when we look at HHS, we're talking about 90% of people with HHS are actually diagnosed with type 2 diabetes. Now, there are cases where type 2 diabetes has caused DKA, especially with other contributing factors associated with it. And obviously, type 1 diabetes can still put you in a state of HHS as well. So they're not solely dedicated to one side, whether you're insulin dependent or non-insulin dependent, because anyone who's researched anything about diabetes knows that it's a very complex and overlapping term, so we can't just lump it in. Now, in our line of work, we have become a lot more lenient with people with diabetes. Either they have diabetes on entry or they develop a case of diabetes in the umbrella term, and their obviously service is allowed to stay. So it's becoming more and more prevalent. So whilst it's still low because we still have quite a healthy community, it is still probable. Okay, and it can happen extremely rarely, but can happen in the absence of diabetes. But I will caveat that with saying that the first time it happens in the absence of diabetes, really it's usually an undiagnosed type 2 diabetes in HHS case. Okay, so the characteristics of DKA and HHS is obviously hyperglycemia and an absolute or relative low levels of insulin. Clinically, the difference is the severity of dehydration, ketosis, and metabolic acidosis. So DKA is characterized by hyperglycemia, high levels of ketonic bodies, and metabolic acidosis, obviously associated with the ketone bodies and the high sugar. Whereas HHS doesn't have those high levels of ketones, so it doesn't often have the associated acidosis. But it does have an extremely high osmolarity, which means that they're often far more profoundly dehydrated. Now, as mentioned, DKA often occurs in those insulin-dependent diabetes, and also occurs in those type 2 or non-insulin dependent diabetes under extreme cases of stress, serious infections, trauma, cardiovascular emergencies, things like that. HHS, on the other hand, is obviously more common in the non-insulin dependent, but has also been seen in the dependent. So they often overlap. And the cases of overlap between the two is 27% of admissions with hypoglycemic states. Now, the reason that's important to understand is we won't have the ability on the ground to really measure the diagnostic criteria for either one of these states, okay, because it involves a lot of pathology and a bunch of math as well. Okay, so the fact that 27% of all the cases out there have an overlap between the two really highlights the importance that on the ground, if you have a person in an emergent state with high glucose levels of the blood, based on things we can test, then our management always starts the same. So try not to get your head wrapped around the nuances between the two, especially when you're on the ground, and consider the importance of the patient. But just to provide a little bit more context on pathogenesis, DKA's case, generally speaking, as we know, the body shifts into a major catabolic state when it breaks down glycogen stores. It hydrolyzes triglycerides from our adipose tissue and metabolizes amino acids from the muscles. The release of triglycerides and amino acids into peripheral tissues becomes substrates of glucose and ketone bodies for the liver, which causes hyperglycemia and ketose body productions that play a central role in this metabolic compensation. And it's the compensation aspect of ketones and glucose that causes that hyperglycemic case and ketosis as well. And the ketosis mixed with the glucose causes the metabolic acidosis. So you need to be aware that it often occurs to people that don't have enough insulin or completely are dependent on supplementary insulin. And what that means is when you need to go through cellular metabolism, your body often wants to use glucose, but glucose can't get into the cell, therefore metabolism can't occur. Therefore, it uses these alternate means that have a huge amount of byproducts in their metabolism, only supposed to be used short term. And it's those byproducts en masse that causes this diabetic ketoacidotic state. Now, in the absence of those ketone bodies or significant amounts of acidosis, we move into the realms of that HHS. So when we talk about DKA, we're mostly always talking about a near absolute absence of insulin. When we move to HHS, on the other hand, we're talking about a large amount of glucose, but it has a sufficient amount of insulin to prevent the need of mass ketogenesis and lipolysis. It can still go through glucose genesis, or in some cases it still uses gluconeogenesis with the amino acids, which can contribute to the overall osmotic value. Okay, but the biggest difference is it's the sheer presence of glucose that really causes this hyperosmotic value, but it doesn't have the breakdown of tissues and byproducts in order to cause a significant acidosis. So we're purely dealing with a very high glucose state, which in turn increases osmolarity, and that osmolarity causes profound fluid loss. And through the fluid loss, it moves into things like organ failure and things like that. Okay, so that's the two different states. But like I said, on the ground, what you're going to see is a high blood glucose level, and in some cases, you're not going to know the difference because of that overlap, which is why the management, especially in the immediate sense, is often the same. So let's talk about the management now. In the event you identify someone in this hypoglycemic state, regardless DKA or HHS, the most important thing you can do is identify it and evacuate. Now, I cannot stress that enough. Evacuation is the real treatment for people in this state. Now, in order to put your index of suspicion out there, you can have patients presenting with polyuria or excessive thirst. Okay, now that's very much the case when we're dealing with HHS. When we move into DKA, it can lead to more acetone breath or Cushmouth breathing, and both can cause abdominal pain and confusion. Okay, so in reality, very vague symptoms, very vague signs. Remember that a bunch of these often are attributed to stress, injuries, infection. So the best thing you can do is really have a BGL as a basis of your baseline vital signs for a lot of patient presentations. Now, obviously not all of them. You can be clever with roll ankles and things like that. But if someone comes with a decent infection or a decent injury, BGL should be part of your routine, because the symptoms can be difficult to physically see unless you're at the extreme end. And it often means that you need to discuss certain things with the patient in order to get the information of thirst, polyuria, abdominal pain, that sort of thing. Okay, so BGL on routine can and have picked up a lot of these cases, even when the clinician wasn't initially thinking of it. And when you get the BGL, take a note. Generally speaking, anything over 11 generally is more attributed to DKA. When you get up to the 33, and that's not a typo, 33 millimoles per litre, then we're looking at HHS. Now, whilst in the immediate sense it won't change, that number will mean a lot as you move down the line. Now, we need to start treatment, and the treatment is evacuation. But while you're waiting for evacuation and while you're going through the motion of getting them prepared for evacuation, getting a cannula in is essential. Getting 2 cannulas in is better. If you can't get a cannula in, then you get an intraosseous injection in, so in order to do infusions. Okay, you must have access. Okay, there's no other choice. Okay, you have to have access. Okay, an IV is the best. If you don't have it, you go IO. You start 1,000 mils of normal saline. Okay, 1 litre normal saline in the first hour as you're evacuating them. You constantly do vital signs, including cardiac monitoring. These states are known to cause cardiac problems. So you get the monitoring on early and you take note of any abnormalities. Now, in the event you're in a treatment team or a facility that has a little bit more to play with and you're still waiting for evacuation, you can do a little bit more that can help clarify and quantify whether we're looking at DKA or HHS. This is not really the important stuff. An evacuation to a facility that has insulin as a minimum is better than wasting time doing this stuff. If you are waiting for evacuation to come because you don't have your own evacuation platform, okay, or if they're not in that bad of a state, emergencies speaking, and you want more evidence, then you can do this. Okay, but the management of these patients in the long term cannot be done in our environments. Because of the statistical probability associated with diabetes and the lack of diabetics we have in service, we do not waste resources on managing these sort of conditions to the optimal case. Now, if our paradigm changes and we go to an environment where we need to, then obviously that will shift. But for now, we're not equipped. We need to understand that. We're not equipped to deal with these states. Okay, but just to clarify, you can take bloods. You can get ketones from urine. Okay, full blood counts for infections. UNEs are viral because you will often need to correct electrolyte levels. Liver function test is a good one to have because a lot of these cases can affect the liver or is caused by an affected liver. You want a good blood glucose and a blood gas as well for the associated acidosis if it's present or not. Best to do a pregnancy test. Pregnancy is one of the leading causes of DKA because of your gestational diabetes risks and unknown diabetic states, things like that. Now, if you're waiting and you have a few other toys to play with, then you can look at correcting the potassium, especially if it's less than 5.5. How much you give and how you infuse it actually depends on the level, which we'll discuss soon. You can also put an IDC in order to get an accurate fluid balance, okay, because that is going to be very important, especially in cases of HHS, because of the profound dehydration, and you will need to correct the levels associated with the osmolarity with pathology in order to really treat HHS as well to prevent end organ failure. As I said at the start, you do this if you have time, if you're waiting for evacuation to come in order to take this person to a definitive care facility. Now, once they get to the definitive care facility, because we work in all environments, it's important to know, one, what sort of needs to happen with these patients, and at the same time, we need to highlight why it is best for us not to keep them. Because the first thing they need, or in conjunction with all the first things they need, is IV fluids. Now, I know you're thinking, well, we can do fluids, we carry fluids, but it's not as simple as just throwing fluids into someone. The first hour is simple. You start with a litre of normal saline, as we've discussed. Now, in case you're wondering why we use normal saline instead of compound sodium lactate, especially in the knowledge that we just mentioned potassium and high levels of potassium can also occur, we don't want to use compound sodium lactate because of the lactate, because of the risk of associated acidosis and the link with lactate. If you're in a state of sepsis, lactate's only going to get higher, which is never good for anybody. So sodium chloride is the fluid of choice. It is not crystalloids, it's sodium chloride. We need to ascertain if they're in a state of shock. So if their systolic blood pressure is less than 90, basically speaking, then we want to give 20 mils per kilo in the first hour, and we want to correct the states of hypertension, sepsis, or cardiac event. Now, DKA can often start with a deficit of 5 litres. It's quite common, whereas HHS usually starts with a deficit of 10 litres, which you want to correct. A lot of these cases will throw out a lot of fluids, but the electrolytes imbalance will be profound. So from there, you go through a series of giving more normal saline, generally speaking, and after the 4 to 6 hour mark, you target urine output to that 0.5 mil per kilo per hour. Pretty similar to burns. So all that, technically, we could do. But where the complexity comes in is we need to be really careful about the sodium levels that we're giving in this case. Okay, and we actually want to do an equation known as the sodium corrected for hyperglycemia. When you're in a state of hyperglycemia, what you're measuring in your pathology is not actually 100% true sodium. So you want to have sodium, and then you want a plus 25% of the glucose level. Okay, now that sucks because you have to do that all the time. In the event you get over 145 millimoles of sodium, then that really needs specialists in order to basically give design fluids and a whole bunch of other medications to correct, often done in an ICU. Okay, so that's fluids, not as simple as you think. Potassiums, yep, we already mentioned that needs to be given, but that will either depend on if you've got peripheral access, central access, what the levels are, whether it's 20 millimoles over 2 hours or over 1 hour, or you can give up to 40 millimoles over 1 hour in a central line or over 2 hours in a peripheral line. And it's also important to make sure that insulin isn't started in critical cases before potassium is corrected. Because insulin itself can actually draw a little bit of potassium out, as we know, because it's used for hyperkalemia. So we don't want to lower someone's potassium further to the point that cardiac arrests occur in the event of trying to fix potassium in the absence of insulin. So you've got to balance it. And as far as balancing insulin goes, insulin starts off relatively simple when we're dealing with moderate cases of KA or HHS, but it only starts simple for the first injection. And then you really have to hand over to ICU for some very complex equations, realistically, and I'm not going to go into them, okay, because if you're not in that environment, you don't need to know, and it's not the focus of this particular presentation. Okay, so all things, they need constant monitoring, they need all this measuring. You can also need to fix magnesium levels, phosphorus levels, prevent DVT, and also take care of their underlying condition that put them in this state. So all this stuff needs to happen concurrently, so it's a true medical emergency that in reality starts with insulin and builds from there. So if you don't have insulin on board in your facility, then you don't really want to hold on to these patients for long. You want to evacuate them to an appropriate facility where they can get the appropriate care in order to really look after them. So that finishes us on the hyperglycemic state. Bottom line is identify initial management with fluids, evacuate to an appropriate facility. That's it. Don't let your ego get in the way. Look after the patient and move them on to a facility that can look after them. Right, now that we've summarized the highs, let's spend a little bit of time focusing on the lows. Now, the lows themselves, again, are heavily attributed to medication errors or medications that aren't quite right associated with diabetes. Okay, so that's it. So again, diabetes and alcohol in this case are the big reasons why people get hyperglycemic. Now, people can get hyperglycemic for a bunch of other reasons, okay, but it is very rare. And for the age-old adage of people getting hyperglycemia for exercise, that's extremely rare, and it takes a significant amount of effort and in a lot of cases neglect to do so. So you need to be working really hard with very little food intake and sort of the wrong food intake in order to get to this state. Now, I'm not saying it doesn't happen, because absolutely it does. Okay, we've all seen patients in this state based on the training we do. Okay, but normally speaking and statistically speaking, it's very rare and it takes a huge amount of effort to get there. Now, when we talk about non-diabetic hyperglycemia, there still are a huge amount of causes of non-diabetic hyperglycemia. Now, these can broadly be divided into insulin mediated, so hyperinsulin states, or states that are independent of insulin themselves. So when we look at insulin mediated, we're mostly looking at those endogenous causes of hyperglycemia due to hyperinsulinemia. This is mostly caused by obviously taking too much insulin, but in that other cases, we're talking about hyperplasias and neoplastic formations in the pancreas, around the beta cells, causing an increase in insulin, or tumours that mimic the beta cells of the pancreas releasing insulin itself. So not releasing the insulin, but releasing the triggers in order to cause the insulin release. Okay, so that's the main one. When we look at the causes independent of insulin, then it's really alcohol, organ failure from critical illness, adrenal failure, pituitary failure, severe sepsis, anorexia nervosa, obviously starvation, and then your exercise brings into that as well. Now on top of that, we also have a series of drugs that if people abuse, and they're not even the fun drugs, we're talking about beta blockers, angiotensin receptors, antagonists, things like that, that can also cause this state. So as you can see, the causes of non-diabetic hyperglycemia are quite varied. They're really, really broad, which brings us to the thing to consider that if we have a patient in the field and we're dealing with fit, healthy, cream of the crop sort of patients, then it's easy to assume that it was exposure or hard work or something like that that caused the hyperglycemic state. But it could be something more sinister. They're still human. They can still get subject to a lot of these conditions and causing neoplastic formations. So because exposure and exercise are probable, but not very prevalent, we need to consider the other causes, which means we're not going to do it in the field. So regardless of the management and how well they respond on your treatment, we need to evacuate them. Okay, so that's the bottom line. Now, because we're not dealing with the very common cause of diabetic, too much insulin, bang, hyperglycemia, the severity and the characteristics of the hyperglycemia we see can be very non-specific. Now, what we do know, but what a lot of people don't attribute to a hyperglycemic state, is in the presence of hyperglycemia, we know that the low sugar levels causes a reduction in insulin and an increase in glucagon, which obviously activates the production of glucose through the liver. Okay, that's well known. But what also happens at the same time is the pituitary gland and the cranial nerves as well will also stimulate the release of other hormones. Okay, and those other hormones are from the autonomic nervous system, and those releases will cause the release of both androgenic and cholinergic responses, which gives us a lot of our signs and symptoms. So when you have an androgenic release, so the neurotransmitter androgen release, then that's symptoms you'll see will be pallor, tremors, anxieties, and arterial hypertension initially. Arterial hypertension can also be exacerbated by secondary catecholamine release from that androgenetic stimulators, okay, like epinephrine and norepinephrine itself. On top of that, cholinergic release predominantly involves that sweating, hunger, and paresthesia that you feel. Okay, so if you don't have the glucose stores, then you won't get the increased glucose production, but you will get the androgenic stimulants, which gives us the symptoms, and you will get the cholinergic responses, which is where your hunger and your sweating comes in. So when we have the characteristic pallor, sweating, people often don't connect how that's happening as a result of low sugar. Well, now you know the connection. On top of that, there's also an increased production in the growth hormone and ACTH, which obviously causes the release of cortisol, which occurs because of that low hyperglycemia. In the event the person stays in that hyperglycemic state for a varied amount of time, but a longer amount of time than is really healthy, then we start getting those neuroglycopenia symptoms. And that means the neurosymptoms caused by sugar within the brain, and that includes your drowsiness, confusion, visual impairment, and you often can get those signs of aggression, that sort of thing as well. Now, this can lead into motor deficits, seizures, and loss of consciousness. Now, if you have a severe long high state of hyperglycemia, that's when you get your organ failure, cardiac arrhythmias, arrest, and permanent neurological damage. Okay, so don't forget that neurological damage long-term can occur from states of hyperglycemia, hence the emergency. So in the event we have someone who is hypoglycemic, we need to discuss what we need to do on the ground. And again, identification is key. Not many patients are going to rock up and go, I'm hypoglycemic. Okay, so you need to look for those signs that we spoke about, those androgenic, cholinergic signs to take a BGL. Stupor, confusion, change in personalities, all those sorts of things can as well. Now, don't get me wrong, there's a myriad of other things that cause these symptoms, but get a BGL. Okay, ascertain the level of consciousness and the level of cooperation. The reason we do that is because that will dictate what sort of medication we give. If the patient's hypoglycemic, which means less than 4, but they're conscious and cooperative, then we start with glucose gel. And if it's less than 4, we give 15. If it's less than 3, we give 20 glucose gel. If you don't have glucose gel, then you raid the ration packs. You raid the food, and you get the high sugar foods, condensed milk, M&Ms, sugar itself from water, okay, and you give them that, followed by a carbohydrate-based meal. Okay, so look at what they've got, feed them carbohydrates. After about 10 or 15 minutes of feeding them, you take the glucose again, and if it is less than 4 still, then you do it again. You give them more sugars, and you keep doing this. But you arrange for evacuation to get them out. Because remember, our people shouldn't be hypoglycemic, and are never hypoglycemic for no reason. So further investigation is needed. In the event that they're not conscious, they're not cooperative, okay, so they're unconscious, feeding, or you just cannot feed them because they're not cooperative, then we need to go for the IV or IO route, and we need to give 10% glucose. And we use 150 to 200 mils of that over 15 minutes. Now this brings on a little bit of a logistics problem because 10% glucose is what we give. Now obviously that comes in a litre bag, but a bunch of us are quite tight on space. Okay, so we don't often carry bags, 10% glucose, that are designed for one condition that has a very low probability of occurring. So we do carry 500 ml normal salines, and carrying a couple of vials of 50% dextrose is less cumbersome than carrying litre bags of 10% glucose. So despite the PCCM recommending a 5% glucose bag with a vial of dextrose over a litre, we can alter that mass and thinking based on stuff that we carry. Okay, so the way to make a 10% glucose bag in a 500 mils of normal saline is you first remove 100 mils of the normal saline and then you add the dextrose. 50% dextrose is 25 grams. So when you add the 2 vials to the 500 mils, it'll be 50 grams of dextrose glucose with 500 mils, which is your 10%. Now you need to be very careful that you don't open the outlet and squeeze out 100 mils. You need to use a needle and syringe. That prevents an air embolism getting into the bag. So it's the whole double sticking a bag rule. It's the same thing applies here. So you take 100 out with a needle and syringe and you put the dextrose back in. And then you need to infuse 150 to 200 mils. Now, if you were to hang the bag up and run it, you are very likely to give too much. Okay, you're too likely to get involved with something else and give too much. So because you need to infuse it over 15 minutes, okay, and it's best to have a conversation with the doctors beforehand doing this because of the states that people get in for hypoglycemia. Okay, so just play it by ear realistically. But you don't want to run the bag, you want to infuse it into a cannula with a syringe. Okay, so if you get a 50 ml syringe, you draw it up 3 times from the bag and you infuse 1 syringe over 5 minutes. That's it. Now, if the person regains consciousness to the point that they're no longer unconscious and in that conscious cooperative state, then you can go straight back to oral. Okay, because oral is a lot safer to give, and it also gives us evidence of whether or not their actual metabolism is working as well. Now, we're going to keep doing vital signs every 15 minutes, and as we evacuate them out of there. In this state, they drop back down below that 4, then we give them more glucose based on their conscious and cooperative state. Once they revive, and sometimes it can be magical, it sort of makes you feel a little bit like a demigod giving glucose, because they can wake up on the end of your syringe and a person is completely unconscious, almost unresponsive, and then all of a sudden they're conscious and talking to you. Okay, it's quite a surprising thing to see. It still surprises me. We still need to think about what to do next. Remember, this person should not have been hypoglycemic. The fact that there is an anomaly and something has happened, either in training, in them, or something else, that means that they're in this state. So we need to evacuate them with full notes, and they need to go under full investigations to rule out any of the other causes of hypoglycemia. It's not good practice to assume it was exposure, cold, heat, or exhaustion/starvation that put them in this state until you've ruled out the other causes. Okay, that brings us to the end of our glucose emergencies. I hope you got something out of it. Even though it's something we do talk about a lot and it is mentioned a lot in emergency states, we need to be aware and we need to be real about the probabilities of both hyperglycemic and hypoglycemic states. If they happen in our demographics in the absence of diabetes, something has gone very wrong and unpredictably wrong with the patient. Okay, a lot of the protocols you read, a lot of the information that is available is based on a demographic that includes a lot of people taking insulin or having uncontrolled levels of a spectrum, which is diabetes. Okay, diabetes is a very complex metabolic disorder that involves a lot of study and a lot of differing managements. Because of that, it is difficult to extrapolate what we need to do in our demographic with people that really aren't the same as every other demographic. So in the case that someone gets into these positions, we need to be real about our managements. We need to get them out of that emergent state, keep them alive, obviously, but then we need to evacuate them all the time. Hypoglycemia is far more probable than hyperglycemic states in our demographic. Okay, and if we do see a hypoglycemic state, evacuation, priority 1, is the best treatment for them to a facility that has insulin at least. Hypoglycemia, they can be in a state, you can fix them, don't keep them in that training environment. If you can remove them from a non-care environment, do so. If for some reason you can't, and obviously I know those reasons exist, then keep monitoring, make sure they stay fed, keep monitoring their glucose levels, but they need to have investigations when they can. But until next time, take care.